States. What I was going to speak about, and I sometimes speak quickly in English and don't speak any Portuguese, so one of your questions could be, can you slow down? So that's fine, please just let me know. Just a few goals of my talk. One is to talk about the challenges for the current approach to post-market safety of medical devices from the U.S. perspective, but it's really not that different in many parts of the world. The second is to think what we often think about and has been very effective in many areas of health services research is looking at claims-based administrative data sets and how that might help us to understand the safety of medical devices, but there are significant limitations. Very quickly, what the U.S. has been doing to address these limitations and these inadequacies of the current approach to monitoring the safety of medical devices. But what I'd like to talk about for most of the time is the last point, which is the notion of active surveillance, monitoring data, accruing data sets in a continuous fashion to assure that the performance and outcomes from medical devices are within our expectations. And this is something that unfortunately is nascent. It's just beginning in the U.S., but it is used throughout other industries. Active monitoring of the performance of the technology that one might be deploying. So one of my first points is that devices are different than medications. And certainly in the U.S., there are many reasons why monitoring medications routinely are facilitated by looking at claims-based data. One of the most important is that there is in the U.S. A national drug code that identifies medications such that one can go back to claims-based data, both federal and state-based claims data or even private insurer data, to really understand exposure. Who got what patient got what drug at what time. Devices, unfortunately, implanted devices in particular, don't have a uniform documentation code. There is, by law now in the U.S., an implementation, very slow, of unique device identifier, but that is going to take years to come to the level of implementation of the drugs. The other problem with devices, especially implanted devices, is that they are linked, they are inextricably connected to the procedure in which they're implanted. And a complication associated with a procedure in which a device is used, is it device-related complication? Is it the device? Is it the procedure? Or is it the patient? So you can imagine very complex need to risk, adjust, and understand. Another challenge specifically within cardiology is that we have rapid iteration. We have devices that move through from testing to wide use very quickly, and then they're replaced. And the brief period of time that they may be available may be so quick that it's hard to even know were they working the way we had hoped, were they safe. And finally, from a more theoretical perspective, both the physical use of the device as well as the procedure in which a device is implanted is dependent on the skill of the operator or the experience of the center. And just to give you an indication of that, just in the interest of time, move to a small study that was done back in 2012 looking at a national registry, the National Registry for Interventional Cardiology in the United States, and we looked at 100,000 deployments of a very simple device. This is a device that closes, seals an artery after a catheterization procedure. And what was stunning was that the acute outcomes from the use of this device improved dramatically over the experience of the operator across 100,000. Now this was a new device, so this was the first 100,000 patients who received the device in the the United States after it was approved for commercial use. But the outcomes of the device, when measured against the experience of the operator, was very consistently improving. This is actually the 95% confidence interval, improving from around 93% to nearly 99.5% after adjusting for the patient factors. Doctors get better at using the devices with more experience. That's sort of self-evident. What's not so self-evident is the advice from the FDA is that one only needs to use this 10 times before you're considered competent to use the device. But we would say that that's not what we're observing from the national data. So now a bit of a whirlwind, quick tour through the how are devices assured to be safe in the United States. It really is voluntary, passive reporting. If a clinician or a hospital identifies that there was a problem after a device was used, it is reported to the FDA, the Food and Drug Administration. The FDA gets 300,000 such reports a year. That represents probably less than 0.5% of device-related failures because it's voluntary. The problem with this voluntary passive submission of data is that there's no denominator information. The FDA does not know how many patients receive the device, nor what the risk for failure in that particular patient might be, and that the reports are lousy, they're bad, they're incomplete. Many times they don't even identify the device that the patient received. And so the utility of this data for accurate assessment is limited. Now, recognizing the limitations of passive reporting, one can look at monitoring existing data sets. And so we have administrative data sets, and then for devices or for conditions, there are a variety of registries available in the United States that have detailed, structured data around the clinical information, which is so important for devices. So we know that administrative claims data are large. These data sets are representative of a large population. They have great advantages in being able to track longitudinal, time-based outcomes. Generally standardized coding. The registries have the advantage of having detailed clinical information, and most importantly right now, we know what device a patient may have received, but they're very limited, and only certain devices have registries in the United States or elsewhere. The disadvantages are also self-evident. There's limited, basically whatever is a strength of one is the weakness of the other, so we have limited clinical data on the administrative side, very hard to do any kind of adjustment, meaningful adjustment. Lack of specific device identification, and then the registry weakness is again the limited number, the scope, and oftentimes very limited longitudinal outcome. There have been efforts in the United States to really build upon the administrative claim side for looking at safety, but this has really only been done for drugs. And the best example, the biggest example, is the Sentinel initiative, which is funded by the FDA since 2011, which is a collaboration of many very large healthcare organizations together. And so there's 140 million lives now accessible to the Sentinel project, but it really is only an administrative claims data, not only, but that's the data that was available. And it's augmented by pharmacy data, but almost nothing else. And so while this can work for drugs, it really cannot work for devices because there is no exposure information in that data set, or at least not general, only if there was a code for a specific device, which is very rare. There's often codes about a procedure, but that doesn't specify the device. But Sentinel works. Sentinel works for drugs. Very quickly through a structured common data model, if there's a question from the FDA, to look at all 140 million patients that are covered in these 18 different healthcare organizations. A distributed query can go out to these common data models at each one of them. The data stays at those local centers, but you can answer questions very quickly, but only at a superficial level. So you can only do very rudimentary adjustment, perhaps by age and gender, or age and gender and where they live, but very limited. But at such scale, that may still be helpful to support or refute a significant risk of one drug versus another. And in this case, it was two agents that were drugs that were used to help support smoking cessation, right? And there was some concern, some case reports that indicated varenicline was higher risk for cardiovascular adverse events than bupropion, but it turned out that there was, in the sentinel review, no significant difference, and therefore gave assurance to the FDA that there wasn't a dramatic high increased risk. There's very limited, just as an example, I only found one example where medical devices were really monitored with purely claims-based data. So very, very few examples of using claims data to see to look for safety of medical devices. This happened to use an unusual circumstance where a new device came out. There happened to be a code for reimbursement for that device that led to a unique opportunity to use administrative data. FDA has then recognized that we have a problem because the voluntary reporting is quite limited, about 0.5%, and it's often inaccurate. And that administrative claims data, which works well for drugs, is not working well for devices. It's not effective. So there's a variety of programs that the FDA in the United States has recommended, and I guess the most sweeping and most important is the unique device identifier system that may hopefully help claims data be more useful. Again, it will probably only give us good exposure data, but may not allow for the level of risk adjustment that we need. And we're going to focus in a moment is developing new methods, which is the active surveillance paradigm. I'm going to skip ahead in the interest of time. We mentioned device registries. There's lots of registries that can get very expensive. You think about what a registry is. It's extracting data from healthcare records. Someone is abstracting and writing it down, or there's code that is pulling the data from electronic health records. But that's all added on to the routine costs of caring for patients. But at the end of the day, you get high-quality, detailed data, which can be very, very useful. But they can vary in quality from single large center, the Duke database being an example, all the way up to some very interesting national mandatory registries. So transcatheter valves that are being used for aortic stenosis is a new technology. That's actually in a mandatory national registry with very high quality and good longitudinal follow-up. So you have to be cautious, just like in any other aspect of health services research. What is the quality and the cost of the data that you're trying to use? In Massachusetts, Sharon Rees has actually led for several years the development of a cardiovascular registry, actually two, one related to cardiac surgery, one related to interventional cardiology, for the purposes of quality monitoring. And we've been fortunate to collaborate using these registries as an example for active surveillance. I'll skip ahead for a moment. So active surveillance is meant to fill the gap between the voluntary reporting, which will always be needed to recognize unexpected, unanticipated relationships. You always want people paying attention. You know, a person has a funny reaction to some medication, or you need to have spontaneous reporting. But active surveillance lives somewhere between the passive event reporting. Sometimes we have post-approval mandatory studies to make sure in a smaller or a larger population than an original trial, does the device look safe? We have these registries which are occurring more and more, but almost all of the analyses that are done for registries are really retrospective. someone comes up with a question and we look backwards. And what we're proposing is active surveillance, which is looking at some data set in a prospective manner, continuously saying there's a new device that's come available. Can we just make sure that it's not killing people, right? Is this device safe enough? Is there any hint of a significant signal for this particular device? And so what I say is that it's analogous to a smoke detector, operating in the background, watching accumulating data, and if there is a signal of an outcome associated with a device after risk adjustment, at least it's hypothesis generated to inform what type of research could be done with the registry or with the larger claims-based data. Look for that signal in an alternative data source. So active surveillance for devices needs clinical data to do this risk adjustment, and it's continuous. And we want, in an ideal world, to have an accumulating data set that we're watching as a new device comes online, and we compare it to, in a somewhat rigorous way, to existing devices or alternative therapies, or even just expectation for what should happen for that device if there's nothing similar. And the value is in detecting low-frequency safety signals earlier than you might detect through just waiting for someone to spontaneously say, wait a second, there's a problem. It's always hypothesis generated is the bottom line, because we need to confirm any such signal with more detailed epidemiological review. To support active surveillance, it's used in industry all the time. Active surveillance in industries outside of healthcare all of the time. Quality surveillance is active surveillance. Environmental monitoring of air quality is active surveillance. So there are lots of tools outside of healthcare that can help us. We developed through an NIH-funded project, Sharon Rees was a co-investigator, a set of software that is generalizable, easy to attach to a variety of data sources to support this prospective monitoring using risk adjustment. By the way, the slides will be available to anybody who wants, so please, you don't have to take notes. And we used this software to monitor the Massachusetts data set, looking at the safety of heart stents, coronary stents. At the time, there were only 2 drug-eluting stents available in the United States, and this was looking at when the second one came to market. And what we did was we used the method of propensity matching to look at the cumulative, in this case it was post-procedure myocardial infarction, heart attack rates after getting the stent. And the blue, okay, so this is time at the bottom. This is event rates, very low, from up to 3%. We were looking at whether there was a difference in the population of patients who got the new stent versus the ones who contemporaneously were getting the old stent, adjusting for as many clinical variables as we could through a propensity match algorithm. And this is the blue band is the 95% confidence interval. The 95% confidence interval for the control group, and the dots are the cumulative rates of events for the new stent. And what we saw and did not expect to see, we looked at 20, I think, device outcome pairs, 7 different devices, about 3 outcomes per device. This was the one that popped out. It turns out that the Taxus stent appeared to have a higher post-procedural MI rate, heart attack rate. It also turns out that that has subsequently been found in large retrospective analyses over and over and over. In fact, most recently, the DAPT study, the dual antiplatelet study, which is published in the New England Journal, also finds a relationship between this particular stent and MIs. Maybe it's related, but it's only hypothesis generated. But it certainly was the case that there was about I think it was about a 1.6-fold increased risk of stent thrombosis. So I'll just skip ahead to this, the propensity matching, just to suggest that one can do this in a rigorous way, prospectively, And because it's a bit, the term in the United States is cookie cutter, right? It's a very simple method. Set up a propensity match and let it run, and just look for the outcomes over time. It's not a very complex risk adjustment, but it's just a first pass, a first simple test. This was another example looking at the device failure rates for implantable defibrillator leads. This is a survival analysis which shows from a very small registry, only 3 hospitals, but even with just a small registry, we saw a dramatic separation between an existing lead and a new lead called the Medtronic Fidelis lead, where the rate of failure of the Fidelis lead was dramatically different. And this is a survival, so going down is bad. And so by the end of 25 months of surveillance, one could see a statistically significant signal for a higher rate of failure. The curves separated so quickly. This is propensity matched survival. Again, a very simple method that can be done prospectively. A little hard to do really good risk adjustment prospectively through multivariate approaches, but this one is easy to implement. Unfortunately, in the US, the recall didn't occur until month 60, and so this is the time savings of what active surveillance is intended to allow. If there is a problem, can you identify it earlier? Can you prevent patients from being exposed to a potentially problematic device before current approaches lead to the recall of the device? There are about 3 bad recalls in the United States a year. They're always, every time, we say, we should have known that sooner. How did we not know? They knew, we knew. The registries from Scotland, from Australia, or elsewhere often help us find them. So just one more example of active surveillance, and that is that we've been able to take that software and use it against the national registry. The national registry, cardiovascular registry, where I showed you the learning curve before, where we've started to do this. And in this case, we had a hypothesis, which I guess is always a good thing. And the hypothesis was that we were concerned about one device. And so we said, we're going to study this one device where we're concerned. The device happened to be a closure device, so again, a little plug on the artery. And this one is called the one we were worried about was the MINX device. There was hints in the literature and in experience that there was a problem with this device. And then we decided to take some, what we presumed would be negative controls. So we're going to say, select some procedures that are done at the same time in the same registry where we don't expect there to be a difference, and let it run, let the data run. So we were comparing the MINX performance, a special device, against other vascular closure devices, propensity match, looking for similar populations. Separately, we're looking at what are called thrombectomy devices. There's a bunch of them, looking at them, propensity match. We don't expect there to be a signal here. We're worried about whether there is a signal here. Again, this is propensity perspective matching. And a formal protocol of analysis. There's predefined high-risk patient subsets, and then predefined further exploration if there was a signal to be found. So the first is the negative control. This happened in every case where we looked at one thrombectomy device against another. The numbers get huge for device registries. We're talking about 45,000 implants of these devices, but you can see how the performance of the exposure of interest is virtually identical to the experience of the patients who got an alternative device with the same indication. And this was running, this actually ran prospectively, so it really was, we were taking a quarter's worth of data when it became available and doing the analysis automatically in the background. Within, well, the data stays at the data owner. We just put the software at the data owner, so there's no exchange of information at all. It just sits there like a smoke detector in the kitchen. This is what the MINX device looked like against other, this is the population of patients who got alternative closure devices. This is what MINX looked like. This was disappointing. It wasn't disappointing that it was high. It was disappointing that it was high from the first quarter. That you didn't have to do monitoring, right? You just had to do an analysis right here. That was disappointing. But there's ways of overcoming disappointment. But it is dramatic that the rates of vascular complications, which is a principal interest, outcome of interest, was high. We protocol mandated alternative risk adjustment. Again, a little tricky to do. We have to take historical data, build a model, apply it against the two populations. Invariably, when we try this, it always looks worse than the propensity match. Somehow, the propensity matching, the way we implement it, does a little bit better in smoothing out the unmeasured confounders than when we use more traditional multivariate, simplified logistic models.
Just ask a question. In most of the plots that you're showing now, there's always this trend of increased cumulative complication. Is this explained really by the learning curve?
It might be. That's what we have hypothesized. And we also very much want to try to incorporate the learning curve as a sort of covariate, as a risk adjustment in the analysis. But it's hard to do. And methodologically, I think that this is an area that methodologically we would love to work on, to say how can you appropriately incorporate learning into the assessment of technology. And we can get back to that, but that's a really fundamental question. Yes, we see this all the time. Outcomes get better over time. Secular trends. They get better by the populations. Local populations go back one. Even this, there's actually a downward trend of the control population. Oh, I'm sorry.
I just following up with what you said. I assume that you have a unique identifier for physicians, so one of the ways of tackling the learning curve might be to look at the cumulative frequency of the individual physicians, and on a quarter basis, you might be able to adjust for that to see whether they have a novel or frequently used device.
Yes. We get there in a moment, actually. So we have these pre-specified subgroups. Again, this is coded. The smoke detector is sniffing just for the female patients, just for age greater than 70, just for diabetic patients. There's different ways of approaching this, but we see that the signal looks consistent, right? It's the same signal. What other questions? Now we're going.
Now we're going. Good.
Quick question. Just you talked about the propensity score matching as a risk adjustment method, and you told us that you do it prospectively, if I understood it right. So how actually do you do it? Every patient that gets in a new propensity score is calculated by the background program or something like that?
Right. So it is correct that the propensity score formula is created early. It can be updated an option to update the propensity score over time. We have not done that. So that it's a static propensity score, but each quarter, every new patient is scored against that static score and is matched to a contemporary patient with that static score. One difference is the question of replacing and rematching, and we can do it either way. These are without rematching, but the ICD was done with rematching, and sensitivity analysis showed very little difference, at least in these data sets, doing it one way versus the other.
But you update your method, propensity score match every now and then.
You can choose to do that.
You're not doing
This was not done. This was you set the propensity score parameters at the beginning, and then you let it roll. But it's a great methodological question of what is more appropriate, and it can easily be done either way. This was an interesting post hoc analysis. The post hoc analysis, we went back to the registry. Again, this was done prospectively, and we said that the signal was present in the first quarter. Let's go backwards and see when it would have been available from the start of the registry. And it turns out it would have been available, the signal would have been present in the second quarter. The disappointment of finding a positive signal so early is tempered by knowing that we can go back and still find it. This was an interesting one to account for still limitations of our matching. And that was, we adjusted for two things. One was the experience of the operator, and the second was the preference of a center to use one device versus another. Because one could imagine, as a clinician, that people choose to use devices for different patients for reasons that we can't exactly model in a propensity model. So we tried to take those centers that used only a lot of the MIGS device and compare it to only centers that used a lot of another device. And it definitely tempered the severity of the difference, but the difference between the performance and it persists. I think it's still, it went from 1.7 as a relative risk to a 1.4 as a relative risk. But there's something to be learned from that. So it's saying even at those centers that use it all the time, and the doctors who use it all the time, it still doesn't perform as well as the alternatives. But this is a tiny minority of the patients who are getting the device. So doctors are using the device for high-risk patients and having bad outcomes. And this is a common lesson in cardiology that perhaps one ought to focus on a device that you use a lot rather than, in the exception case, use a device that you don't use very often because it appears that that is associated with high risk. We have a few other projects. We are already starting an ICD national registry project with the limitations of propensity matching and survival-based propensity matching. And we are hoping to be able to apply this against the TVT, the transcatheter valve registry, but that is not yet approved. That would be powerful because that really is a really new technology with very important implications for costs, for safety, for device choice, that sort of thing. So I think I will quickly conclude. Spontaneous or voluntary reporting of medical devices safety is limited. UDI is going to help us, especially with the big data approach of identifying exposures. Active surveillance is really applicable mostly right now to device registries, but can fill in some gaps of what the first two approaches can provide. We understand it has to be hypothesis generating, but it can be informative. There is a group that the FDA has put together. Sharon Reed is one of the leaders of this group called MD-EpiNet, for Medical Device Epidemiology Network. And that certainly is a group that is considering all of these options in the best way to explore medical device safety, post-market safety. So with that, I thank you again for the opportunity to come and discuss with you the work that I do.
Being the moderator of this session, I'm going to use that role to ask a question before we go next one. And I know it's kind of picky, but I noticed in your slide for the Mini Sentinel, I think that you said there's something like 140 million lives in the Mini Sentinel. And when you gave the slide on the tobacco example, I don't know how many people noticed the confidence interval for that effect. I'm a statistician, so I did. It's very wide for the tobacco question. And I was just curious, is it just a small number of people getting it? It went like from 0.47 to 1. I don't know, it was very wide. And with the big data, 140 million lives, I was just curious, is that, yeah, so 0.7 to 1.47, that's a wide interval.
So there is the 140 million is the total sample.
Yes, exactly.
I believe that, so I'm just trying to remember, I think that the population studied got down into the 10,000
Yeah.
patients.
Yep.
But even amongst the 10,000 patients, there were subgroups, and maybe the pharmacoepidemiologists in the room might be able to help advise. They had to eliminate a lot of patients for whom they weren't sure of the indication. So
Yeah.
there are patients who get these agents who are smokers, but who also have maybe receiving these medications for other reasons.
Okay.
So the population got smaller and smaller and smaller,
Yeah.
and I think that that likely led to it. I don't think that there was particularly sophisticated analytic methods
Yeah.
being used that
Yeah.
sort of
Okay.
blew up the confidence interval.
Yeah.
I think it was sample size getting smaller and smaller and smaller.
Just one of those, we talk about big data and 140 million lives, and I looked at that interval, I thought, well, that's a wide interval.
I mean, a quick comment on that, Professor, from my estimation is that the variance or the width of the confidence interval is related to the event rate rather than the denominator. In this case, hopefully the event rate, which was death, I think, was rather small, or some serious adverse
You're right.
event was very small. The total numerator number.
Thank you very much. It's really very interesting. A quick question now. When you detect all these problems post-marketing, do you get feedback to manufacturers to change the clinical trials? Is there any sign, any lessons you can teach them to do better work before we? Thank you.
So in the first few examples, no. In the first few examples, these were analyses done on a data set in the absence of the manufacturer's participation. In the TBT registry proposal, it's intended to be part of the risk assessment, risk evaluation that the manufacturers would use. And so it's a process of communication of who are the stakeholders. So in the proposed TBT registry, the steering committee would include the manufacturers. They would get the signal report first. They would have 30 days, 60 days to interpret, contest, or assess the signal, mostly contest, so that the report that would then go to the FDA would have the signal, but also what the manufacturer's interpretation, because the manufacturer does have access to many other data sources. And again, these can be certainly confounded. Having said that, it's also been reported by some of the leading manufacturers, they'd rather know about a signal early than late. And so the hope is that if it were to be FDA mandated to have this as part of the overall post-approval process, it would just be one of the many inputs into their overall responsibility of assuring safety. And they do change registries or trials. If they saw a strange signal for stroke, it may be that that would get into the next trial. But the hope is it does need to feed back.
Armando, and then...
One more question. This might be a little bit outside of your area. You're definitely more concerned about the clinical aspects of quality of care. But I was wondering, what is the real economical impact of this type of surveillance? How important it is? Because definitely, this type of questions can only be addressed with national registries. This is not type of research that you can do with a small cohort of patients, and this is very costly, as you said earlier. Are there economical studies really showing the benefits of the cost? Cost benefits of this type of?
No, so I think it's a great question, and no, there have not been economic studies. We are undertaking, there's a partial answer. So right now in the US, manufacturers spend about $1 billion per year funding post-approval registries that only they control. So $1 billion a year is spent collecting data. What's done with that data is very unclear and remains in the control of the manufacturer. From FDA public health perspective, might that $1 billion be spent better by creating links from electronic health record systems or using the Sentinel type approach for active surveillance? MD EpiNet approach. So money, one way of looking at it is money's already being spent, but just inefficiently. And as you mentioned, it is not feasible to have registries for all devices, but perhaps really high-risk devices ought to, or new technologies. But I think it's a very valid concern, a very valid critique to say it's awfully expensive to do such a thing. It's less expensive if the registry already exists. And so maybe one should say, well, what exists today, and should we be leveraging that data?
So last question, and we'll switch on.
Okay. Well, it's a question probably we don't have the time to answer, but could you please tell us a little bit about the marketing authorization process of devices in the US? We know that for drugs, this is already established, but for devices, it's not so clear, and there are some differences between the US and Europe regarding the marketing authorization process. And lastly, we could indeed forcefully obligate the post-marketing surveillance. Do you think that would be important from the policy, in a policy, health policy level?
So certainly there are differences between European and US approval process for devices. Devices in the US are either approved through what's called the PMA process or cleared through a less intense process called 510K. It is intended that high-risk devices that could lead to high morbidity or mortality would go through a PMA process which requires some level of pre-approval clinical evidence. It doesn't always have to be a randomized trial, but in cardiovascular, it almost always is a randomized trial. Yet the trials are often much, much, much smaller, and a single trial is often sufficient to support PMA. Like in Europe, approval does not immediately mean reimbursement. So there are distinctions between approval, but typically an approved device is reimbursed under Medicare, which is the largest of the governmental payers. Should the post-market, I think, I am on the side that post-market monitoring of high-risk device safety ought to be an essential component of sort of the overall product life cycle for devices from a health policy point of view, but I have to acknowledge I don't know how much it will cost.
But probably if you are able to prevent some adverse events, you're going to...
The last point, do you remember the time savings we talked about for the Fidelis lead? It's an example, it's anecdotal, but 70,000 patients were treated in the US between when we knew from 3 centers that there was a problem to when the device stopped being sold. 70,000 patients filling a football stadium. That's a high-risk device. Those 70,000 patients incurred several $1 billion worth of care to explant the device. So there's costs, but rare.
You should do a cost-effective
Yeah.
analysis